Okay, so moving on past the improvement of cerebral perfusion. Um, the care of the patient who's had a stroke has been such a large push to care for these patients more proficiently in the past. I'm going to take a guess, probably the last 5 to 10 years. JCAHO, the governing body for hospitals, um, came up with the core measures for ischemic stroke care. And these are the core measures that are required to take place for a patient who is admitted to the hospital with ischemic stroke. Um, it starts out with venous thrombosis prophylaxis, including SCD hose, making sure that they are placed on an anticoagulant if they have atrial fibrillation or atrial flutter, that they are discharged with an antithrombolytic medication, that thrombolytic therapy in the presence of a thrombus stroke is less than 4 hours from symptom onset. Again, these is important to get a patient to a stroke center, that the antithrombolytic therapy is evaluated by the end of hospital day 2, and that the patient is discharged on a statin, and that stroke education is not only provided and documented, but that there has been an assessment for rehabilitation and where that rehabilitation will take place. Most hospitals that are stroke centers have they call them different things, but a nurse who is in charge of making sure that the patients, and I'm not talking about the care coordinator, the person who's coordinating their care with outside agencies. The most hospitals that are stroke centers have a clinical nurse leader who is a stroke specialist, who is in charge of making sure that the patients are getting these core measures for the ischemic stroke care and following the JCAHO guidelines. I know at Atrium they're called they're the clinical nurse leader for stroke care. I know the hospital that I work at Caramont, they are the stroke navigator. Different wording, but it's still a nurse, usually master's prepared, who is in charge of making sure that patients who are being cared for an ischemic stroke are being taken care of using these core measures that are in place by JCAHO. So, moving on to looking at the nursing interventions for patients who have suffered a stroke. So the first nursing interventions we're going to look at is promoting mobility and ability to do ADLs. So a patient with a stroke is at risk for aspiration. So best practice is to maintain an NPO status until swallowing can be assessed. With that, we want to, it is best practice for these patients to be NPO until swallowing is assessed. With that being said, these patients are also at risk for malnutrition, especially after being in the hospital for extended periods of time, because what happens is these patients get placed on an NPO status and they are not started on either TPN therapy or tube feedings, or they don't get their swallowing tests done. So even though best practice is to maintain the NPO status until swallowing can be assessed, we as the nurse need to make sure that the patient is receiving the proper nutrition in order to, maintain their either their weight and their albumin levels, because these patients can be at risk for malnutrition, because what happens is everyone's so worried about their neurostatus in a critical care unit that, and perhaps they're on a ventilator, that we don't take care of their nutritional needs. And so, yes, it is best practice to maintain an NPO status, but we also need to make sure that we are covering their nutritional needs, whether it's through TPN, whether it's through enteral feedings, whether it's by feeding the patient, to prevent the risk of malnutrition. We also need to make sure that if the patient has a flaccid arm or leg, make sure that we're always picking it up joint to joint and supporting it. Make sure that it's not going to flop off the bed. Make sure that it's not being pressed up against the side rail. When we turn the patient, make sure that that arm and leg are not getting left behind, where they're back behind the patient. When you do move that extremities, make sure you're moving them at the joints. And don't just pick them up by the wrist and sling them around. Make sure that you're picking them up joint to joint, and make sure that you're supporting them on pillows, and make sure they're not left behind when you're turning the patients. Make sure that we start rehabilitation as soon as possible, whether it's in the acute care setting of just getting the patient and putting them in the chair, whether it's just making sure that we're doing that turning every 2 hours to prevent pressure ulcers, and to, you know, my favorite word, to help with pulmonary hygiene, to make sure that they're not getting atelectasis, make sure that they're being able to get up their secretions, to make sure that they're not getting a pneumonia, make sure that they're on some type of some type of thrombosis prophylaxis, so they don't end up with a DVT, which can lead to a PE. So these are all things that the nurse needs to be making sure that he or she is taking care of while the patient is in that acute phase post event, so that they can be ready for rehab in a timely fashion. So again, best practice is to maintain MPO status, but with that being said, we need to make sure that the patient is getting their nutritional needs met, because in the acute care setting, they are at risk for malnutrition after a stroke. Remember, if the patient has a flaccid leg or arm, to make sure we're packing them up at the joints and that we're not leaving them behind. Make sure that we are preventing complications such as pneumonia. Make sure that we've got them on some type of venous thrombo-therapy, so that we're not running a risk for DVT, which can lead to PE. Make sure that we're not having pressure point issues. Make sure we're continuing that pulmonary hygiene to prevent atelectasis and pneumonia. Can you see these are big points with me? Again, talking with patients, nursing interventions, promoting communication. Speech problems are usually a result of a stroke on the dominant hemisphere. So remember, with the majority of the populace being right-handed, their dominant hemisphere is the opposite side. Aphasia is usually injury to the cerebral hemisphere. They present, so you want to make sure you're presenting ideas in one sentence, which is, you know, for some of us who talk a lot, such as myself, that can be very difficult. So you want to just make sure your questions or answers are very simple. Like, instead of, okay, Mr. Jones, go ahead and get up to the chair. That's a lot of words. Just say, Mr. Jones, Mr. Jones, we're going to the chair. Or Mr. Jones, we're going to sit up. And then once Mr. Jones is sitting up, Mr. Jones, we're going to put your arm on this side of the chair. Mr. Jones, we're going to stand. Mr. Jones, follow my lead. We're going to start to turn. You just have to make it in one, not we're going to get up to the chair and assume that he's going to know what to do. So we have to start with, Mr. Jones, we're going to sit up. We say, very simple, very one-step commands. Also, which is very hard sometimes to remember, we want to make sure that we are speaking slowly, but not necessarily loudly. If the patient does not have hearing loss, you don't have to yell at them, but you do need to speak slowly and very clearly. The patient may need flashcards or other alternative forms of communication if they aren't able to identify their words. And remember, never rush the patient or correct the patient when they're trying to speak. Give them plenty of time to get their words out. If they get frustrated, a nice smile and try again will get you a long way. Remember that dysarthria, which is the slurred speech, is usually loss of motor function of the tongue or of other speech muscles, where aphasia is usually from the injury. Does that make sense? From the cerebral injury, but the slurred speech is usually because of motor function loss of the tongue. Okay.